السلام عليكم. اهلا وسهلا بكم في ال 44 Libyan Cardiovascular webinar والسكند ليكتشر بتاع الاي كارديولوجي اي بي ليكتشر سيريس، جزء من الليكتشر سيريس بتاع جمعيه القلب الليبيه. اليوم معنا الدكتور محمد اللبيدي. دكتور محمد اللبيدي is assistant professor في جامعه Southern Illinois. الدكتور محمد أعطيه الجزء الأول المحاضرة في شهر 6 وتو الجزء الثاني المحاضرة. الجزء الأول دكتور محمد ناقش الانديكيشنز فور بيس ميكر والبيزكس بتاع البيس ميكر indications، والجزء هذا حنتكلموا عليه البيزك فانكشناليتي اوف ذا بيس ميكر والترابل شوتينج اللي هو جزء مهم. نحاولوا ان دكتور محمد يحاول ان هو يشارك ب examples practical تساعد في المانجمنت اوف patients with pacemaker on a daily basis. فدكتور محمد معانا اليوم. وبالنسبه للاكسبرت بانل معنا الدكتور فتحي إدريس والدكتور خالد بوزقية. شكرا لحضوركم والفلور is all yours دكتور محمد.
شكرا دكتور يوسف. Share my slides. بسم الله الرحمن الرحيم. Okay. Last time we stopped at this slide. The first, as Yusuf said, the first part of this lecture was basically bradyarrhythmia as an indication of pacemaker. So I'm gonna try to focus, and this is just the basics. يعني هذه القواعد الأساسية للpacemaker and the basics of troubleshooting of common problems. It doesn't go over the details. The first thing about pacemakers, there's two kinds of pacing modes. There's a unipolar pacing, which is an older device, used to be mainly unipolar pacers. Most of the devices nowadays is bipolar, but you can switch for whatever reason a bipolar pacer to unipolar. And the difference is unipolar, you pace from the tip to the can. So the antenna for any activities is this current. So you're more prone to sensing artifact than if you pace from the tip to the ring, which is the bipolar. That's why we call it bipolar, because the current of pacing is between those two portions of the lead, which is the tip and the ring, or the cathode and the anode. There's two kinds of leads. There's active fixation lead and there's passive fixation lead. The difference between the active is there's a helix mechanism that you screw into the muscle versus passive. You just put the lead and eventually it will scar up into the muscle. Leadless pacemaker, we touched on that briefly. Basically, you have these fixation tines that hook into the trabeculations. And the pacing, the cathode is the tip of the leadless pacemaker and the anode in the back. So how this lead is hooked back to the can, there's two rings that talk or get connected to the lead. One of them is talking to the electrode coming from the ring, and the tip is the back one. So basically the electrode that goes inside the lead that's coming from the tip gets hooked into the back part of the pacemaker. This is a zoom in on unipolar and bipolar. The difference in 12 lead EKG, sometimes you can tell, is that the spike of unipolar is more prominent than bipolar. Bipolar spike usually, sometimes you don't see it on 12 lead EKGs. And if you, this is just cartoon for the lead, shows that the conductor is connecting from the tip of the lead all the way to the can. And as we said, the pacing is from the tip to the can, versus this where there's two conductors, one coming from the ring and going back to the can, and one conductor coming from the tip going to the can. And as we said, disadvantage of unipolar is you're more prone to have artifact issues. This is more zoom in and how bipolar pacing happen. It's from the tip to the ring again, from the cathode to anode. An important pacing concept is coming from Ohm's law. Ohm's يقول إن الvoltage and the resistance is equal voltage divided by current. And that gives you the impedance or the resistance. And the resistance is combination of resistance in the lead and resistance in the tissue. It's important in acutely when you're putting a pacemaker, and also if you're troubleshooting an old device or any device. So if you have and it varies from one manufacturer to another depending on what kind of lead. If you have a very low impedance that suggests a break in the insulation, اللي هو الغطاء بتاع الconductors. The way I remind myself and people in training is like الهوز اللي هو التوبو، لما يقعد في شرخ في التوبو فتكون في ليك للواتر فالريزستنس تكون اقل والبريشر يكون اقل. The other example, if you have a kink in the tube, you will have a higher resistance, which is fracture of the conductor. So if you have a high impedance, think about lead fracture. If you have low impedance, insulation break. If you're putting a device acutely, high impedance can be a sign of perforation. We talked about this. I'm not going to spend time on it. Pacing in the RV should give you lift bundle and give you R and V6. Pacing from the LV, it gives you the opposite, give you a right bundle. So if you zoom at the spike that you see on 12 lead EKGs of the pacing, if you want to think about it, what's that spike represent? It represent an energy that delivered over time. So say you're telling the device, okay, I want you to pace the RV or the atrium by 3 volts and deliver this energy over 0.4 second or 1 second. And this is basically a translation. So you have a leading edge of the spike of the energy delivered, the time that the energy delivered, and the trailing edge of the energy. And this happens over whatever time you set it for. Why that's important? It's important عشان انك تحدد the threshold. We say the threshold of the device. And this is a very important concept for implanters of pacemaker and following these pacemaker. So always when you deliver energy, you're going to a muscle by a lead, you're going to deliver it over time. And you try to be very efficient in finding a good energy delivered in a reasonable time to save battery. As you become more efficient in picking up the energy, you also want to avoid non-capture zone. So for example, let's take this example. This is a device. It's basically, if you look at the curve, if this is the capture threshold, what that's mean? That's mean the device is capturing at 2.5 volt and the energy is delivered at say 0.4 milliseconds. So we say that's the capture threshold. What that mean? It means that if you try to deliver 2 volts over 0.4 millisecond, the myocardium won't contract. That's below the threshold. So this is a forbidden zone. If you use higher energy over a longer time, you're going to capture the threshold. You're going to capture the myocardium. So you want to pick the sweet spot, which is usually in this area, where you use as minimum as possible voltage with a reasonable amount. There's a plateau for the duration of delivering an energy. So there's limit on how much you can deliver energy to save the duration for delivering energy to save energy. Sensing is an important concept because you can oversense. Basically, you tell the device, okay, I want you to sense any activity in the, say, for example, the RV that's above 2.5. And you can run into issues of oversensing, like this example. Now, instead of sensing an R wave, which the RV lead should sense, you're sensing T wave. If you do the opposite and you increase the sensitivity and you overdo it, Now, instead of you over-sensing T wave, now you're not sensing R wave. So the sensing is an important concept of pacemaker. You don't want to undersense or oversense. Sensing is a complex process where the analog data on the tip of the lead is converted to digital. It goes through amplification, filtering, it goes through rectifiers, and then it passes through the threshold. And the sweet spot or the good zone is something like this. So you want to pick signals with certain millivolts and also certain hertz. So you can pick R waves, P waves, and the VF if you have an ICD. And you want to avoid picking up electromagnetic interference, myopotentials, and you want to avoid T wave oversensing by doing low sensitivity on the device. For subcutaneous ICDs, it's the same concept, and because it's subcutaneous, you don't have a lead inside the heart, you run into issues of oversensing, and you can see T-wave oversensitivity is a problem with subcutaneous ICD. The point of this slide is sensing is an important function of the pacemaker. It's when you sense an event, you adjust your algorithm, and also you make decision, or the device makes decision based on sense event. Remember, pacemaker intervals is based on milliseconds, so we convert rates to milliseconds. It's very simple. If you have a rate, you divide 60,000 by the rate. So for example, if the rate of the patient 40 beats per minute, that's equivalent to 1,500 milliseconds RR. We call that the ventricular rate. If the atrial rate is different, it's a different rate. If we say the rate is 600 millisecond, it's 100 beats per minute, and so forth. That's important because pacemaker language uses millisecond, doesn't use rate, especially for intervals. Anti-bradycardia pacing codes. This is very, very important concept for junior cardiologists. So when we say this device is VVI, or when we say this is a device in a mode of VOO, or it's DDD, what's that mean? Or DDDR. Each letter means something. So the first letter means the chamber that you're pacing at. For example, if we say the first letter is A, that's mean you're pacing in the A. The second letter means chamber that you sense at. So when we say AA, that's mean you pace in the A and you sense in the A. The third letter is what's your response to sense event. There's two options. Either you trigger a subsequent pacing event, or you inhibit. And if you have most of the devices nowadays have both function, triggered and inhibit, we call it dual function. And then you have rate modulation, which based on activities of patients. So say if you have a device is DDDR, that's mean the device can have a capability to pace in the A and the V. It senses both in the A and the V, and also it can trigger, meaning if you see an event in A, you wait in the V, and the A basically trigger V pacing if you pass the AV interval, and we'll show example of that. Inhibit mean that if you see something in the same chamber that that you can pace at, and you saw activities, you inhibit. You don't need to pace on top of activity. So if the intrinsic rhythm is coming, if you have a V, you don't need to pace on top of V, and we'll show example of that. So this is very important concept. So just looking at the EKG, if you have some of these spikes, you can tell if this is a DDD device. So if you dissect the pacemaker simply, the can has a battery, and it has the logic chip, which basically has the algorithms, timing, crystal clock, and the counters. And there's channels that comes from the A and comes from the V, and there's channels that goes out to the A, it goes out to the V. So for example, this is a DDD device. It paced in the A and it paced in the V. And then in the next example, this DDD device did not see any atrial activity. So it says, okay, I'm going to pace in the A, and then I'm going to wait for my AVI. And there was a ventricular sensed event that happened before the end of AVI, and that inhibited V pacing. The third example, you have an atrial native beat that happened. The device waited for the atrioventricular interval, and it says, okay, nothing happened in the V, it's time for me to pace. The third example, it can be in the same patients, atrial activity happened and ventricular activity happened, the device didn't need to do anything. So sometimes you see abbreviations in pacemaker. No one memorized these abbreviations. When you print out an interrogation of any device, it has the code in the back and each one what it means. So you don't spend time in trying to memorize this because it's a lot of abbreviations. There's few common. With time, you're just gonna remember it. And each company has a different coding and abbreviation. So don't waste your time memorizing these. Important concept, the intervals and refractory periods of the pacemaker, and we'll go over these fundamentals in the next slide to avoid one potential complication in the pacemaker, which is pacing on top of T. So back in the days when we used to do a lot of DFTs for ICD to check for if it's working or not, we basically pace on top of T. Why is that? If you remember the action potential at phase 3, 4, that's a relative refractory period, and the myocardium is vulnerable. So if you pace on top of that, you can induce VF. Imagine if you have a device that's programmed VOO, and you're pacing, you're not looking where's the beginning of the QRS, where's the T. If you have a native T coming in and you pace on top of T during the last half, you can easily induce VF. Luckily, this happened very infrequently. That's why be careful when you see a device that's programmed VOO. Make sure there's a reason for that, and it's not by mistake. And be careful with pacing on top of T. Okay, what's the 4 fundamentals of pacing? The 4 fundamentals of pacing and pacing cycles. Number 1 is lower rate interval. What's lower rate interval? Lower rate interval is basically you tell the device, I want you wait for a certain time for the R to come. If you don't see it, you pace. So for example, here you have an atrial sensed event, and then you have a V pace, and then the device waited for, we'll talk about atrial escape rhythm, atrial escape interval. Atrial escape interval came in, so there was A paced, and then it waited for the AVI or the lower rate interval, and then V paced. So the time from this spike to this spike, because there was no native beat coming, we call that lower rate interval. A second important concept is, and this is important to avoid pacing on top of T, which is ventricular refractory period. So I'm sorry, ventricular refractory period, which is the time from this paced event until a certain time after the T wave, which basically you're telling the device, and تقول للdevice, okay, بعد ما أنت pace the ventricle, I want you to wait, for example, 400 millisecond or 350 millisecond. I don't want you to do any ventricular activities just to avoid pacing on top of T. Okay, so this is the second concept. The third concept, we kind of touched on it on a previous example, is the atrioventricular interval, which is the duration that you set up the device to wait from atrial event to a ventricular event. So you tell the device, okay, I want you to set up a sense AVI, and you can have sense AVI and you can have paced AVI. You will say, okay, from paced atrial event, I want you to wait, for example, 200 milliseconds. If you don't see anything coming at the V, I want you to pace. The same for sense AVI. You can set it differently from paced AVI. You will say, okay, from a sensed atrial event, I want you to wait for an X amount of time, 250 milliseconds, 200. If you don't see anything coming in the V, pace in the V. Okay, so this is the third fundamental. The fourth fundamental, we kind of touch on this one, is atrial escape interval. Atrial escape interval, it comes from the lower rate interval and the AVI. So it's basically the time from a ventricular event to the time when you say, okay, the device, if you saw a ventricular event, either paced or sense, wait for this duration. If you don't see any atrial activity, pace, and then wait for the atrioventricular interval. If you don't see any ventricular event, I want you to pace. Okay. A fourth fundamental concept, it's very important, and we'll touch on it with examples later, is the PVARP, or post-ventricular refractory period. Basically, you tell the device after V pacing, I want you to wait a certain amount of time, say 400 milliseconds. I don't want you to listen, I don't want you to act on any activities in the atrium. We talked about the ventricular refractory period. Let me just go back. So this is different. PVARP is different from VRP. VRP is basically, I don't want you to pace in the ventricle at all after a sense or paced event for this amount of time. PVARP is a different, and we'll talk about why this is important. Both of them are important, but this has a different reason. Is if you pace or sense anything in the V and something happened in the A, I don't want you to act upon it. And this is what we call post-ventricular refractory period. The third, it's under the same concept, is the TARP, which is the total atrial refractory period. It's basically a summation of the atrioventricular interval and the PVARP. Okay. All right, let me talk about more clinical stuff. This is a single pacemaker, single lead pacemaker functioning at VVI. So you can inhibit and you can pace. So you can see the device is pacing. Pacing is a ventricular event. So it inhibited and it timed itself to the lower rate of the device. And then it waited for another event. It didn't happen. It paced again. So this is a simple single lead pacemaker. I will skip this slide because this slide will be easier if I show the next one, the upper rate behavior. So the upper rate behavior, if you have a dual chamber pacemaker, you tell the device, okay, I want you to pace at lower rate, say, for example, 60, upper rate 120. And say if the patient is young with complete heart block and he's able to mount his heart rate above 120 easily. So one behavior or two behaviors that we see in those kind of patients when they go above 120 beats per minute is the device will say, well, you told me that you want me to track the upper rate of the atrium up to 120. And after 120, I'm not sure what I'm going to do. So in this example, the device is tracking. So it's seeing A, pacing in the V. It's seeing A, pacing in the V. It's sensing A, and it's blocking. But the PR or the AR time is getting longer. And then it senses again and paces in the V. And it senses again in the A and pace in the V. So it's kind of Winky-Bach behavior. So we call, because of a pacemaker, we call a pseudo Winky-Bach behavior. And then if you go faster, the device will just conduct 2 to 1. This is a common problem in young patients with complete heart block for whatever reason. They exercise and suddenly when they exercise, they feel tired. So you try to maximize the upper rate behavior to avoid this or tracking rate. You add other features. There's different algorithm to to solve this problem in young patients. So this is upper rate behavior. Another important feature of pacemaker to avoid potential issues with pacing is ventricular safety pacing during cross window interval. So let's look at this here. So you have a dual chamber pacemaker. You're pacing in the A, you're pacing in the V, simple. There's the post-atrial VP, and then you have what we call crosstalk detection window, which is a certain time after a paced or sensed atrial event. So you tell the device, if you sense anything during this window, I want you just to pace in the V. And this is a safety pacing feature. Why this feature is an option, or most devices have it nowadays. There is an issue of what we call cross-talking. What's cross-talking mean? Cross-talking mean you pace in a chamber and you sense in the other chamber. Say, for example, you pace in the A, and for whatever reason, you have a far field signal that's sensed in the V. You don't want to pace in the A, and then there's a little bit of delay, and you sense in the V falsely, far field, and you tell the device, okay, I sense an event in the V, which is not correct, and you inhibit incorrectly. That's why you have this feature. So this feature is to prevent cross-talking, basically. So that's one. That's another important feature of and fundamental of pacing. Let's go over troubleshooting some pacemaker malfunction. Number one, oversensing. So let's take this first example. So you can see I tell my fellows and students is always look at the EGMs and EKGs, and the translation of you as a physician should be based on that, and what the device thinks is what you see on the tracing, where you have what the device thinks, basically. So you can see here the device is oversensing an artifact, and it's labeling that as a fast rhythm, and that's falsely inhibiting pacing. So this is a problem. That's why we tell patients who have pacemakers to avoid, if they are dependent, to avoid certain electromagnetic fields, because they can generate these artifacts and can fool the device and inhibit pacing. And in defibrillators, these can fool the device thinking this is VFib and they get shocked. So this is just an artifact, and the device is falsely translating that as a ventricular activities, and it inhibiting, and it's not pacing. Another example of oversensing is due to atrial lead or lead malfunction, fracture, or myopotential in the pectoral muscle or any muscle close by the lead. So these can be these myopotentials or fracture artifact that goes on the lead can fool the device thinking that these are atrial events. So the device will have a lot of spikes, and this is actually not atrial activities. So the device will say, a lot of activities happen in the atrium, I better catch up to it and pace in the V. So now you are tracing an artifact and pacing unnecessarily in the ventricle at a higher rate. So this is another example of oversensing. If you have a device, and this is an example of failure to capture, this is an example of a patient with high-grade AV block. You have a sinus node and V pace, sinus node, V pace, and now you have a sinus that's not tracked, sinus not tracked, sinus not tracked, meaning sinus not tracked, meaning you don't have V pace like here. And this is a patient with a pacemaker, and you have 3-4 beats. This can happen 1 beat. I will show you an example of that. This is a different feature in some pacemakers, but to have it back to back like this, it makes you suspicious that there's a failure of capture or a problem with the sensing. So how you troubleshoot that if you have a failure to pace? So the first thing, you pace in asynchronous mode. You say, okay, the feature of sensing, I don't want that. I just want you to pace in whatever chamber you're at all the time. So either you pace in both atrium and the ventricle all the time, or if you have a single lead in the ventricle, you pace all the time. You say, I just want you to pace, okay? If you start pacing and you don't have any issues like this, then it's a problem with sensing, and then you troubleshoot the sensing. If despite asynchronous, so asynchronous pacing, you'll tell the device, okay, if it's a single lead, pace at VOO, okay? This is asynchronous pacing. If it's a dual chamber pacemaker, you will say the device, I want you to pace at DOO. That's mean I want you to pace all the time in the atrium and the ventricle. I don't want you to sense anything. You notice that when we said DO, the second letter is O. The second letter, we talked about that. That's a the sensing feature of the pacemaker. So this is what we call asynchronous pacing. If you do that, you do asynchronous pacing and the device is still not pacing, then you pace at unipolar. So you switch the device to pacing in unipolar. If you are pacing unipolar, that's mean you have a problem with the connector, like this example. So we said if you have a dual chamber, if you have a bipolar lead, there's two conductor, one coming from the tip that's connected at the usually back ring, and one conductor coming from the ring, connected to the second ring. So if you pace unipolar, you're just pacing from the tip to the can. So if you start pacing now, then you know there's an issue with the conductor. And there's problem with either conductor itself or conductor to the ring. So this is an example of a pacemaker that's not pacing. You can see the tip of the lead is all the way in this one, but not all the way in this one. So the pacemaker insertion was not appropriate, and the lead is not all the way in. So this is how you troubleshoot that situation. If you switch the device to unipolar and still not pacing, failure to capture, then you have either a problem with delivery of the energy or a problem at the tip of the conductor, meaning dislodged lead. This is very important, is the magnet function, because you're gonna face this. If you're in the ER, if you're taking care of cardiac patients in your clinic, you're gonna face a situation one day where you're gonna need the magnet. So if you put a magnet on a device, what that will cause? If you have a pacemaker, if you put a magnet on it, it's basically switching the pacemaker to asynchronous mode, meaning you just telling the device, I just want you to be safe and I want you to be pacing all the time. I don't want you to sense anything. So this is an EKG of a device that before, and now you put a magnet, you can see there's a P and QRS, and then now you put a magnet, and now the device is pacing all the time. And you see spike in the atrium, atrial channel, and spike in the ventricle. So this is for pacemaker. For ICDs, when you put a magnet, you just inhibit the tachytherapy, meaning the shocking and ATPs will be inhibited. The pacing mode of the ICDs won't change based on just the magnet. So this is important. So if you have someone who's coming to you in the ER, he's in VT storm, he's getting shocked every 5 minutes, he's tortured, you're still working on managing his VT storm, you don't have the programmer next to you, just put the magnet on it, it will inhibit the shocks of the ICD, and then you figure out what to do with the VT. If you have a device, it's malfunctioning, you're not sure if it's an issue with the sensing or not, you just want the device to be pacing asynchronous, put a magnet on it and it will be pacing all the time. And then you can troubleshoot the device more by bringing the programmer and further troubleshoot the device, okay? This is very common and it's very important. So, so if you have a device that's under sensing, so we talked about over sensing. Now you have a device that's under sensing. So how you troubleshoot that, or how you recognize that? This is an example of a device that's under sensing atrial activities. So you have a P wave, the device is seeing that, and the evidence says A-sense. You have a QRS, the device is sensing that, and it's saying BV, that's mean this device is biventricular, it's pacing both in the right and the ventricle, but that's not the point. The point is sensing A and V fine, okay? Or sensing A and pacing in the V fine, no problem so far. But now you can see a clear P wave, and the device is not seeing it. Not only that, it's pacing, it says A pace, okay? And now it's sensing V and it's pacing in the V. So there's clearly a problem with sensing, at least in the atrial channel, based on what we see so far. Now, the rhythm keep going. So you have a P, you're not sensing that P, but you see QRS and you're sensing the QRS. You see P, you're not sensing that. And then you see a V sense and so forth. So there's a problem with sensing atrial activity, and you falsely pace in the atrium. The V event happened in the blanking period after atrial pacing. It didn't count that, and it paced in the ventricle. So this is a problem of sensing. If you overcome the sensing, you will overcome sensing issue, you will, or under sensing issue, you will overcome this malfunction. There's another issue that you will face in patients with atrial fibrillation if you don't turn on mode switch. So see, this is a device that has it's dual chamber, and you're telling the device sense A and pace in the V, and the patient flips into AFib, and it thinks that this is atrial activity, and it's tracking that at a high rate. So one way to overcome that, a lot of all pacemaker nowadays have mode switch, and there's ways to detect if this AFib, and I will show you example atrial flutter, and that will tell the device to switch. Okay, I don't need to track this fast AFib. So now this is the other extreme of it. Now you have a defibrillator. You have this is the EGMs from V, and this is what the device is sensing. You can see there's a lot of ventricular activities here. The patient is going into ventricular fibrillation, and the device is not seeing this because this is fine VFib, and probably the sensitivity is high, and you're missing some of this V's. And the device translation is, oh, I see some of this V's, I don't see some of these. So if the device doesn't see this, it doesn't see the VF, and it doesn't shock the patient. So this is failure to detect VF in patients with ICD, and this is life-threatening malfunction. Again, another example of non-capture. This is, you can see a spike, non-capturing, another spike that's capturing. So it's inconsistent capture, and I'm not going to repeat how you troubleshoot that, how you switch to asynchronous. If that solved the problem, it's a sensing issue. If it doesn't solve, switch to unipolar pacing and so forth, okay? But sometimes there's functional failure to capture. This is an example of it. What mean functional failure to capture? Functional failure to capture means that the spike was delivered during the time of the atrium or the ventricle where it's refractory. You won't capture. So this is an example. You have V paced, and then you have a native QRS coming, and you delivered V pacing during repolarization, early repolarization. You didn't induce VF, but the ventricle was refractory, so you didn't capture anything. Not only that, you didn't sense this one. So this one, another ventricular activity that was not sensed, but you paced the timing based on the last V pace, and you paced again. So this is a functional failure to capture. It's not because there's a problem with the device or sense or the capture threshold. This is because you delivered ventricular energy in the ventricular lead during the time that the ventricle is refractory, and it's indicate under sensing. So you're not sensing these ventricular activities. This is very important slide, and I'm going to spend some time on this. So a common issue with pacemakers is what we call pacemaker-mediated tachycardia. And there's 3 kinds of pacemaker mediated tachycardia. There's the kind that I kind of touched on is if you have a patient with atrial flutter, atrial fibrillation, the device doesn't have mode switch on, and basically the device is tracking AFib in the atrium and the ventricle and spacing fast. Okay, the solution of that problem is just turn on mode switch. Very simple. More involved issue is the endless loop tachycardia. And let's just take this example easily and spend time. Okay, so now you have a dual chamber pacemaker. The patient is having sinus beat, no problem, sensing that. You sense the A, and you have the P goes down to the QRS, you sense V. So this is normal, so far so good. Now you waited for whatever interval that you're waiting for, AA interval, and A is not coming, or P is not coming. You pace in the A, you conduct it down to the V, you sensed V, you didn't pace in the V. But it happens that PVC happened. So now this PVC happened in the ventricle, it goes through the AV conduction system, and it causes retrograde activation of the atrium. And this retrograde activation of the atrium is sensed as a P wave in the device. It doesn't know that this is basically a retrograde activation coming from the PVCs that happen in the ventricle. So it says, okay, the A is sensing, let's keep up with it. I'm gonna pace in the ventricle. And the second pace goes retrograde activation in the atrium. Oh, it says, okay, this is the P wave that I saw earlier. I'm going to keep up with it, and so forth. It keep going. So one way to overcome this is you prolong the PVARP. We talked about the PVARP. So you tell the device, okay, I want you to increase the post-ventricular atrial refractory period, so you don't see these retrograde P wave and don't act upon it. So I just want you to ignore this retrograde P wave. So this is a device that has that feature of picking up PMT, or endless loop tachycardia. It's sensing this is basically a PVC happen at some point here, and the device is sensing a retrograde P wave. It keeps pacing retrograde P wave, it's pacing, so forth, so forth. And then the device says, no, this is the endless loop tachycardia. I'm going to extend the PVARP. And the evidence is the device is calling this PMT. So it's going to extend that. And now it didn't listen to this retrograde P wave. And no P wave is coming. I'm going to pace. And now we're back on track. Okay. And you can see the QRS looks different. So this is, if you can look here on the surface EKG, maybe you can see retrograde P wave. So this is a very important slide, and this is an issue that you're going to face if you're dealing with pacemakers. This is an example of mode switch. So this is a patient who had flutter. You can see that he has sinus, and then QRS is sensed, no problem. And then flutter starts. Okay, flutter, first P wave, I'm going to keep up with it. This P wave fell in the blanking period or refractory period. I did not listen to this one, but I'm going to listen to this one. So I'm pacing fast with this flutter, 2-to-1 here, but the device is smart enough that I turn the mode switch. So I tell the device, if you see behavior like this of a flutter, I want you to switch to not listening to that and just pace in the V. So the device switched to mode switch, and now it's not listening to every single P wave, and it's pacing in the ventricle. You can have that same problem with AFib. So this is a device where the mode switch is not turned on. You can see that there's a lot of ascents because of fibrillation, and the atrial lead is sensing that, and the ventricle is trying to keep up with that. So you're pacing V, V, V back to back. Okay. So this is a normal, I'm not going to spend a lot of time on this. Pseudo fusion and fusion, this is more like a concept kind of thing, but this is an important concept to talk about. Some of the devices minimize ventricular pacing, because if you pace in the ventricle all the time, it's not healthy unnecessarily. It can cause heart failure, it can cause AFib. So a lot of manufacturers have developed different algorithms. One famous algorithm, for example, Medtronic, and different company has different nomenclature for it, is the MVP mode, where basically you tell the device, okay, I want you to pace AAI all the time. Don't be DDD unless needed, what that means. So you tell the device pace in A, sense in the V all the time. Pace in A, sense in the V. Pace in the A, sense in the V. And then if you pace in the A and you don't see anything in the V, that's okay. wait for the next beat, and then pace in the A and pace in the V, and then wait for another one, pace in the A, wait, you didn't see anything in the V, that's okay, pace in the A and then pace in the V, and then switch to DDD. So pace in the A and the V all the time. Why all this? This is an algorithm, so you can, if you have someone with a normal AV conduction and you want to avoid, and say if they have a first degree AV block, you want to avoid unnecessarily V pacing. So you're just giving some time to AV to conduct and avoid V pacing. So if you see this, make sure you don't call it sensing problem or failure to capture problem, okay? All right, now we talked about RV pacing. If you pace in the RV unnecessarily, that's not good, because about 5 to 10% of patients with RV pacing all the time, if they pace more than 40% in the RV, they can develop cardiomyopathy. One way to avoid that, as we said, is the RV minimizing algorithm, like the MVP, for example. If you have a patient with a high-grade AV block and complete heart block, and you're pacing all the time, and you have cardiomyopathy, you can replace a single lead pacemaker by putting a bi-V pacemaker, so you pace in both sides instead of one side, and that's more physiological, and that can improve the ejection fraction. Nowadays, we can put in a HIS pacemaker, and that also can improve the function. VVI pacing, you should use a single lead pacemaker if you have a patient who has AFib and you think it's futile to achieve sinus rhythm, and you're not going to go over, you're not going to go after the AFib, you're not going to convert them to sinus rhythm. Then you put them in VVI mode if they have dual chamber from before, or if you're implanting a device, you can put it a VVI or VVIR. You can put a dual chamber pacemaker in patient with AFib if you're planning to shock them out of AFib. I have to disclose that these cases are discussed by expert in and verified by expert in the field in the ACC. So my resources are ACC. Two other resources that I recommend for someone who's interested in EP and pacemakers. I use these myself, so I start with the EKG complete guide and also step-by-step illustrated pacemaker. And I will stop here.
Okay, shukran, Mohammed. Thank you so much. Let me open my video. So thanks, great talk. We covered, I hope, the main points about troubleshooting and the basics. طبعا it's an extensive topic, and I think you did a good job with covering the main points. I have some questions basically, and then we'll address. لو في أي حد عنده سؤال, please type it in or raise your hand. We can have you talk before I can address the questions. Dr. Ayman Smer, go ahead, you raised your hand. Dr. Ayman.
السلام عليكم محمود. السلام عليكم محمد. ما شاء الله محاضرة ممتازة جدا, very comprehensive. عندي couple of questions العلاقة بالmagnet use. لما you have a patient with a pacemaker going for surgery, أنت عارف you have two choices, either you interrogate the device or put a magnet. What's your recommendation in that situation? Do we have to do that or no?
If you use cautery, and the ACC has a recommendation, if you use cautery and it's in the torso close by the pacemaker, and the patient is pacemaker dependent, just to avoid oversensing and inappropriate inhibition, you should put the device in asynchronous mode. And it's the same, but just remember, when you put a magnet on the device, someone need to interrogate the device after the end of the surgery and put it back onto the previous setup before surgery. If the cauterization is away from the pacemaker, rarely rarely it causes significant artifact on the pacemaker that cause inhibition. So I tend not to do even independent patient with the pacemaker. I tend not to switch to asynchronous mode if it's like if their cauterization in the leg or something like that.
يعني the expert divide them into above umbilicus, below umbilicus, يعني above umbilicus, below umbilicus. فيعني أي حاجة في التوركس أو يعني في الأبدمن above يعني حتكون there's risk.
Right. That's what I mean.
Bipolar. I usually say I have like almost a template. Use bipolar pacing if possible. By bipolar cautery, طبعا usually it's unipolar cautery that they use. Short bursts. زي ما قال Dr. Mohamed, and you have to basically you know, put a magnet or a synchronous mode. يعني if it's an ICD, that's not going to work. هذه السؤال بتاع المagnet. ICD is you're going to just disable therapy. Like if the patient is dependent, it's going to be an issue. So basically you have to program the device. Yeah, so.
Yeah, that's so if you run into this situation where you have an ICD patient, for whatever reason, the patient now is dependent on the device and you're pacing, now the magnet won't work. If you put the magnet, you're just going to turn off tachytherapy and the patient will still inhibit with oversensing of cautery. So that in that situation, you need to use the programmer.
تمام. دكتور وائل بوسنينة، وائل كيف حالك؟ أنسنا. هاي تكلم.
السلام عليكم دكتور يوسف. الحمد لله، بارك الله فيك. الحمد لله، شكرا دكتور محمد على المحاضرة القيمة، وبارك الله فيك. عندي سؤال في سلايد 65 لما حكيت على البيس ميكر ترابل شوتينج. you said the mode is AAI، ولما explaining قاعد في V sensed في sense. yeah. So لما هو المود AAI, do we still like sense? We do like V sense?
Good question. You basically so the AI mode is switched here. So here you're still dual chamber. I don't know if you see my arrow. You
yes.
See it on the side. Okay. So here at this time, when you see that square, this is when the device switched to AAI. So now you pace in the A and you sense in the A. Sorry if I said this is a, this period is still DD. You're right. This is still DDD because you're pacing in the A and you're sensing in the V. But now you switch to AAI. That's why you see a pace and you don't see signal in the V. So then you tell the device, okay, pace in the A and the V and so forth. And then you switch. If you don't see a lot of V or you don't see the A is tracked by the V, then you switch to DDD. So this is the MVP algorithm that Medtronic uses.
You usually say 2 out of 4. Yani if you have 2 drop beats out of 4, you turn on the MVP mode. Dr. Fathi Idris وخالد بوزقية, any comments on this? اللي هو basically the algorithm to reduce RV pacing. That's the bottom line. يعني of.
This is like I said, this is a almost virtual AAI mode. It's an MVP mode. So it's different than your typical AAI mode when you completely blind the ventricular channel, you don't see much, but this is almost a virtual. So this is a Medtronic algorithm. So you still see the ventricle, even at the beginning it's A pace, V sense, and then you go A pace, V sense, and then typically the device do it every now and then, prolong the AV interval, and because try to give a chance for natural conduction to occur. And when that drops, and then it goes like Mohamed explained, you pace A and V immediately, and then you switch back to your DDD mode. So the fact that you see the V doesn't exclude this from being an AAI mode. So this is because this is almost like a virtual. This is classical Medtronic. Boston has a different algorithm, and I think that's called, I forgot what it is.
VIP.
Well, VIP, exactly.
AV search.
Oh, AV search, and yeah, exactly. So, but this is a classical and this is actually one of the commonest cause of device malfunction. You get lots of consultation from the telemetry people tell you, okay, the device is not working. We've seen failure to capture that. So they think the third beat you see there, where the A pace, of course, most of these patients have some AV conduction disease, or sometimes it happens at night where the patients are asleep and you get strong vagal tone, and you see the A, typically you see A paced, V sense, and then the next one, longer AV interval, longer, and then you see drop. So this is a little bit a different example. and then you see atrial pace, ventricular dropped, and then you see the double AV pacing means the device try now switching back to DDD mode. Very, very nice.
And I can hand the example. Last week, I saw a patient with physiological noncapture, and she had the AV. She had the MVP mode on, and caused some pacing spikes. So once we turned the MVP mode on and prolonged the AV delays, it fixed the issue. I can show you the EKG. Actually, I just let me show you the EKG.
Can I just make one point, which I think while question is a really very valid question. I think the MVP mode is you pace AAI and you move to DDD when needed. But during testing, it actually tests in ADO, I think, because so you see in your slide, Mohammed, before it was AAI. During the testing mode is actually MVP mode, and then is DDD converted to DDD. So during the testing, you actually sense the V, but you only can pace the A. So his question is very valid, but your slide is still correct because the initial part is actually the MVP mode, which is AAI. The MV testing is in the middle, and then you switch to DD. So it's very good discussion, actually, very good discussion. Very good question.
Yeah, so I think the point of this, when we say MVP, is not a pure AAI mode. It's AAI mode with looking at the V. So you're still watching the V. That's the whole point, right? You want to minimize V pacing, but how you can determine you're minimizing V pacing if you cannot see what's happening in the V. So it's not like the classic AAI. Nowadays, no one rarely, except in Europe, put in a single lead in the atrium. So it's kind of unique mode. It's AAI, but it's MVP, I guess.
Yes.
Let me show you. I'm going to share, if you don't mind, I'll share a slide. Just show you exactly, very similar to what you have. Let me share screen. Give me a second, okay? And then you can share again, Mohammed. I'll just show you that example. I'm sorry, give me a second. There you go.
And Yusuf, Mohammed, to emphasize while you're getting the slide, the point from using this MVP mode to decrease the RV pacing, right?
To reduce RV pacing, yeah. Do you see the slide here with the, like physiological non-capture, almost like, I mean, if you want to call it like pseudo fusion, or do you see the slide?
Yes, we see it, yes.
Yeah, so once I turned the MVP mode off, it was gone. We prolonged the AV delay. As you can see, the patient is not dependent. We prolonged the AV delay, and that reduced the RV pacing. You know, she didn't. So anyways, that's kind of just to يعني الexample اللي انت اعطيته يا محمد يعني. Go ahead محمد, كمل السلايدز بتاعك و put them up. وتقريبا في سؤال, let me stop sharing. في مازال دكتور أيمن, انت do you have a question?
And I said I have two questions about the magnet.
Okay, خلاص go ahead. مفيش أي حد ثاني عنده سؤال.
The second question في ال PMT. A second question about the magnet with PMT, pacemaker mediated tachycardia. Is there any role for magnet in those cases? You know, especially with limited resources, if the interrogation is not available, is there any role for magnet on those patients?
Yes.
Thank you.
This is the easy solution of this problem. If you don't have a programmer available and you just want to solve this problem in the middle of the night, you can put in the magnet. So basically how you solve this by the magnet is basically you will tell the device, I just want you to be in asynchronous mode. So you're not listening to this retrograde P wave. And I just want you, if you're a dual chamber, I want you to pace in the A and the V all the time. So you can overcome this problem. This is a simple, easy fix.
Yeah, good question.
More sophisticated way to treat it is, of course, you extend the PVAR. So the answer to your question, yes, the magnet will solve PMT or endless loop.
Or if you don't have a magnet around, just go in and do VVI. It just stops it. For example, program it to VVI.
Or if you have an iPhone.
Or VOO or. You know,
iPhone 12 Yusuf.
iPhone 12. مفروض تشتري واحد. عندنا الدكتور عبد الغني ابو نواره. تفضل if you
السلام عليكم.
لو عندك سؤال. عليكم السلام ورحمه الله.
كيف حالكم؟ طيبين ان شاء الله.
كيف حالك؟ اهلا وسهلا.
عندك فتحي وخالد، كلكم طيبين. محمد
تمام.
مرحبا.
A couple of comments. Excellent talk, Mohammed. Mashallah, covered most of the stuff. There are a few things maybe we'll think about them later on, especially implantation difficulties and mechanical complications, like what to do if that happens, like perforations and acute decompensation, things like that. These are rare. For the MVP, honestly, in our center, we nowadays don't use that much because of the confusion happens around it. We received lots of calls about those cases. It helps to some extent, but in our pacemaker clinic, we tend to use them very minimally, as you said, Mohammed, to young patients or patients who can't tolerate pacing. The other thing, sometimes we have patients with first-degree AV block, and they get very long PR interval. Sometimes that also confuses people. So that's another thing that we think about when we use this kind of mode, MVP or VIP. The question I have also to you, Mohammed, is not covered here, but just if you have a pacemaker and for some reason you need to upgrade to an ICD, just for the sake of benefit to everybody, what would you do for those patients?
Come again, the question is,
if you have a pacemaker and the patient requires an ICD, and what would you do for those patients when you want to upgrade those patients to an ICD? What's your approach?
So as far as programming, it's like obviously it's a different device. It's totally different. The way we're trained is we don't like to leave leads. So we'll try, if it's a new device, to pull the pacer lead in the RV and put in the ICD, if that's your question, is we don't like to leave the abandoned pacing lead with the ICD leads. Just because of access issues, vasculature issues. There's data on increased risk of infection. Sometimes you have a lead-on-lead artifact and so forth. So I try to pull the pacemaker out once I have the ICD lead is in and with good numbers. If it's a pacemaker that I think it's within a year and a half, 2 years maximum, I think I can just pull it out. I would do that. If that's your question.
Yeah, no, thank you. Yeah, just to cover that. So you use laser extraction for the lead. And
no.
Depends on the duration of how long it's like recent or old. And do you use like, for example, if you need to use a temporary pacemaker to just support the patient, or you just add the new leads and then remove the old leads? Depends on how old are they.
Yeah, so if the device within 2 years, and I think there's, looking at the x-ray, there's nothing strange about that lead, and I think it will just come out, I will put in the ICD lead and just pull the pacemaker lead out. I don't have a laser lead extractor where I practice. If I think it's an old lead, I just send it to an extraction center. We don't have it in my center. Sometimes I just defer, instead of opening the pocket twice. If I'm sending, and I don't recall I have this situation, but in my mind, if this happened, I will send the patient who needs an ICD to an extractor to pull the old pacemaker lead, and I will ask him to just put in an ICD, but I don't extract, if that's your question. No, I don't extract with laser.
Yeah. And an upgrade from a pacemaker to an ICD depends on the scenario. There's a lot of factors that play a role. طبعا بالنسبة للextraction, a class 1 indication is infection. So otherwise extraction has risks. So if the lead is like 20 years old, maybe sometimes just leave it there. And as long as there's a patent subclavian vein, you can add another lead, just leave it. I mean, there's risk and benefit that has to be discussed with the patient. So it's kind of a complicated topic. Maybe we can arrange another talk about lead extraction or kind of more into complications of pacemakers. في دكتور ناصر مسماري سأل سؤال مبكري على الفيوجن والسودو فيوجن. I think you talked about it later. ما أعتقدش لو عندك أي حاجة بتضيفها محمد.
Yusuf, I think the question, another question that's related to the overlap between ICD and pacemaker.
Okay.
A lot of time that we face a situation where you have a high-grade AV block, the patient needs a pacemaker, but the EF is low. So do you go with ICD? The patient, say, for example, this drop in the EF is new, he just had a stent and reperfusion, whatever the reason. So do you just put in ICD since the patient has low EF, or put a pacemaker and reevaluate? And I don't think that the data is very strong on this, except in one situation in sarcoidosis. My practice is if I think the patient just reperfused and looking at the echo, there is viability, and the patient just started on heart failure medications, I would start with a pacemaker and reevaluate the EF in 90 days. If the EF is low, then I put in ICD and pull the pacemaker out.
So there's a paper by Heart Rhythm Society published, I don't know, 4 or 5 years ago to tackle the scenarios where there's no data, there's no studies. For example, like you mentioned, there's someone who comes in complete heart block, just revascularized, needs a, I mean, his EF is 30%, needs a pacemaker. You would just go ahead and put an ICD. The guidelines or that paper does say that it's reasonable to put an ICD because you don't know if it's going to recover. I mean, the patient had an anterior wall MI. Well, is he going to recover or not? You can put an ICD. That's what I do. But if it's a, let's say, a tachycardia mediated cardiomyopathy, someone with AFib, it's obvious tachycardia mediated cardiomyopathy, not pacemaker induced cardiomyopathy. I'm sorry. So someone has normal coronaries, comes in complete heart block, they put a pacemaker in, and then the EF drops down to 30%. Well, if you put a BiV pacer, his EF should improve. So an ICD is maybe not needed there. So Fethi and Khalid, what do you think? Comments about when to put an ICD in those instances?
Excuse me, let me comment about that, Yusuf. So actually, I'm not aware of this paper, but the guidelines is not very clear in this situation. Actually, it doesn't recommend one way to another. I agree if you think the patient will be needing pacing in the RV all the time, you might start with BiV pacing and reevaluate the ejection fraction. But jumping on someone who just had an anterior MI and low EF, who just got reperfused, and you go straight to pace him with an ICD. I'm not aware.
So if his EF doesn't improve in 3 months, what do you do? Do you reopen the pocket?
I do. I open the pocket and I pull the pacemaker lead and I put in an ICD.
I'll find the paper and share it with you so you go over it.
Sure.
Yeah. Yusuf, can you run this is interesting discussion. Can you run it by the rest of the panel?
Yeah, that's what I mentioned. Khalid and Fethi, please.
Go ahead, Khalid.
So I will just start with making comments about the first question about upgrading to an ICD. I think if that is the case, I agree with Yusuf, there are so many factors involved. I wouldn't, as a standard, just extract the lead. I'll take so many things into consideration. The one thing I would just suggest is if you have a pacing lead and you're planning to put an ICD lead, just ensure that you try to avoid putting it in the same place to avoid the interactions, specifically the tip, if you can. But I wouldn't necessarily extract every lead. I think if you have only single lead, for example, VVI, you want to upgrade it to an ICD, there is an argument, just put an ICD lead in. But obviously, you have to take into account the duration of the pacemaker, how long it's been in, the comorbidity of the patient, the location of the lead, and so on and so on. So that's the first question, my first comment. Regarding the difficult scenario where Mohamed suggested that the patient is just recently revascularized, poor RV or LV function, and the patient needs pacing support, it's a very, very difficult scenario. And I don't think anyone knows what the answer is. This is where we tend to have in our center, we tend to discuss these cases in our, what we call MDT. It really depends. We take into account so many things. Do we think that the degree of LV impairment is related to the artery involved? For example, if you think it's only regional inferior wall related to your RCA, and you think this will likely to improve, then there is an argument for just putting a pacemaker, reassessing and upgrading later on if needed. However, if you think the degree of LV impairment or that it's disproportionate to the involved artery and you don't think revasc will improve the LV function, and definitely you think that you will be pacing more than 40%, then we tend to have a very low threshold for putting a CRT-D device in. But all of these cases, they have to go to an MDT, and no one knows the answer, but it's so complex, and I think this is why it involves taking more than one physician to make a decision, obviously with discussion with the patient. So that's my take.
Fatih, do you have any comments on الموضوع ده?
I think I agree with Khaled. I think that's probably the closest approach. The difference, not all low EF after MI or specifically STEMIs are the same. If the patient, if there is, for example, somebody arrives and gets the RE open quickly, LAD, typically the LAD, okay? So open the LAD quickly, put a stent, but the EF is still low, and the patient is kind of tend to be bradycardic, etc. If you think this, many of those patients, although immediately it looks like horrible and low ejection fraction, etc., if you give them some time, it will improve. So these are the ones different than the ones who present late MI. For example, the troponin is already up when they arrive to the ER, but there's still some ST segment elevation suggests a potential aneurysm. And some centers, they still stent them, okay? So when you get there, you get to the 120, like 3-month window of the, Medicare or guidelines, etc. And then you say, okay, wait until reverse. But these patients, even after you give them 3 months, their dead meat, that anterior wall is dead meat. Sometimes I do cardiac MRI in these cases to help me differentiate which one is already scarred and which one is viable. So if you can do cardiac MRI, it may help you. If there's viability, I would just not put an ICD. I will just.
But let me give you an example of someone complete heart block. Would you going to send them for an MRI? And I mean,
well, it depends. If the heart block, if these patients, if you mean complete heart block and hemodynamically unstable, completely unstable, like no escape rhythm, whatever, and then you have no choices. Of course, you have to put a device.
So let me. I found the paper. I did share it with everyone. It's in Circulation 2014. And like I said, maybe the example I said, like an anterior wall MI, and he's a complete heart block, maybe an extreme example. Of course, I agree with you that you have to assess the patient. And if you think it's going to recover, obviously you don't need an ICD, but sometimes you don't know. A lot of times you don't know. So the this expert consensus, again, it's not like based on studies. Expert consensus, they say in patient within 90 days of revascularization who require non-elective permanent pacing, so it's kind of an urgent pacing, so complete heart block, for example, would also meet primary prevention criteria for an ICD, and it's still within 90 days, in whom recovery of left ventricular function is uncertain or not expected. Of course, that's obvious, not expected. Implantation of ICD is a properly selected pacing capabilities is recommended. So they recommend. I mean, if someone is EF is 20%, they had an MI less than 90 days, and he needs a pacer. So what do? You put a pacemaker and then bring him back, reimplant an ICD. Every time we open the pocket, there's an increased risk of infection. More expense. You're putting an ICD. Just why would you? So that's a point. Anyway, I mean, I'm sure there's going to be a debate, a lot of options, but this is a good paper actually as a reference. So.
Yeah, no, I agree. I mean, this is my whole point. It comes to the clinical scenario. Yeah. If you think this is a viable myocardium and you perfuse and you have an indication for a pacemaker, why commit to an ICD before you put a pacemaker and give it some time to recover? That's my whole point. And this is what you just stated in your guidelines. As you said, if in a scenario that you think it's not viable, it's a dead meat, And regardless of reperfusion or not, you think, and there's an indication for pacemaker, it's reasonable to just go ahead with an ICD.
Yeah.
The scenario that I described is you're not sure. In that situation, it's reasonable. I mean, I don't think one approach or the other is wrong. It comes to clinical judgment, and I agree with Khalid that you should have a committee of physicians who do the same stuff.
Yeah.
And talk to them.
Afwan, Mohammed Yusuf, I think, and Dr. Fathi brought very good point about using CMR in those cases. Going to Mohammed was saying, in your clinical judgment, if you don't think this myocardium is viable, right, then like what you said, Yusuf, on this statement saying you don't have to overthink it. If there's indication for pacemaker, this is unlikely to recover. For example, let's say delayed revascularization, thin myocardium in the echo, then yes, go ahead. Because in the past, I think that the standard of care used to be, no, you just put a pacemaker, you wait for that 40 days or the 90 days for an ICD. And the problem, even for physician who would put ICD in that period, they get dinged from the insurance. So just kind of, I think there's no one
40-day rule from Medicare.
Right, okay, so that's an issue. Yep.
We have Dr. Gusby, I think, please, has raised his hand. Please go ahead.
Assalamu alaikum. Great talk and an excellent discussion. But I'm not a smart electrophysiologist. I'm just a humble general cardiologist. So I have simple questions, which are very practical for our patients, and we get asked those questions. And they include, I have two actually. One, I'm going to lump a number of things in one question. So the effect of cell phones, radiation treatment, and those devices that the elderly wear to call for help. Do they interfere with the pacemaker function or not? And the second question is, I was on call last night and a lady came who has an ICD, who came in with appropriate shocks. Now, along the same line as your discussion just now, she has an abandoned lead. But for some unknown reason, don't ask me why, she never had a cardiac MRI before she had her ICD inserted. So when I ordered an MRI, I got an angry call from the radiologist saying she has an abandoned lead and we can't do the MRI. And then I wasn't in the mood to argue last night, so I just said, okay, I'll ask my colleagues in the morning. So why is an abandoned lead a contraindication to a cardiac MRI? And those are my two simple questions. Thanks.
Okay. Khalid, let's give the second question to Khalid, abandoned lead, MRI. He's smiling.
It's very easy. I think I will call your radiologist the following day. He's clearly very upset you called him in the middle of the night. In my opinion, it depends on whether the lead is MRI compatible or not. If is it abandoned, I think there is some people will be concerned about if is it abandoned, will it migrate if you do the MRI? It's unlikely, especially if it's been there for a long time. It's really whether the lead is MRI compatible or not, and whether the whole system. Sometimes you have the lead itself is MRI compatible just because it's been implanted with a different device. The both company will say that this is not an MRI compatible, which is not true. I think the question you really need to ask yourself is if you're requesting an MRI and you have too many leads, is the MRI going to be useful? Because the quality of the images, especially if it's a cardiac MRI, it may be doubtful. But in my view is, the first thing I will do is I'll pick the phone, I'll call my pacing clinic, I'll ask for the lead details, I'll ask for the device details, and then I'll check if they're MRI compatible or not. And that's my view. I don't know if anyone has any comment.
Mohammed, do you have any comments about this?
No, I agree with Khalid, but the problem becomes, and I gave up on these arguments with imagers and MRI a long time ago. At the end of the day, they will tell you that the patient in the scanner is it's under my liability. And for them as a radiologist, abandoned lead is contraindicated to do an MRI. So sometimes I would just we just go down to the MRI with a programmer and just make everyone comfortable and just do it during daytime. But you ask yourself at the end of the day, is it worth it or not worth it to do an MRI and going through all this? Bottom line, I think probably you will be safe. There is a lot of data on abandoned lead and even non-MRI compatible devices and doing MRI, including cardiac MRI. But is it worth it to go through all this trouble with the radiologist? I'm not sure.
Yeah, let me add what you also worry about is, or what the radiologists worry about is heating up, because this is like an abandoned lead that has a tip, and the tip may heat up and cause issues. It's like ablating the tip of the screw there. So that's one issue. But like Mohamed mentioned, there are studies. I think even Mayo Clinic, they have a study that showed it's safe, generally safe, or risk of events are low. Let's put it that way.
Yusuf, what's the difference between the tip of an abandoned lead and a tip that's still hooked up to a pacemaker or a device?
That's a closed circuit because you're connected to the battery, connected to the pulse generator. So it's a closed circuit. But if you have an abandoned lead, like it's a piece of metal in the in the pocket there.
Yusuf, then the tip. Just to counter this argument, for example, let's say that you have a leadless pacemaker. Yeah, leadless pacemaker, you could do an MRI. It's the fact it's very unlikely to cause any trouble. It depends on the radiographer comfortable zone whether they want to do it or not.
Yeah, I mean, even non-MRI compatible leads. I mean, John Hopkins, they have thousands of patients. They did studies. There's this guy, Irani. They have tons of patients that showed it's safe, risk of problems. So I think the MRI compatibility is more of a marketing thing rather than anything else.
Yes, just to let you know. Can I have my input about that?
Yeah, we have a MRI specialist here. We forgot. Go ahead, Wyatt.
Okay. So the main concern is about just the heating sensation, and the patient is going to have it during the MRI. And the other thing is the artifact that the lead is going to cause. There was a recent study published in the JAMA. It was in February 2021, and it was about 150 patients who had like abandoned lead. And they found from there, the abandoned lead is not going to affect the MRI. And from there, many like CMR institutions started doing the MRI or cardiac MRI with the patient with abandoned lead. Now the question is going to affect the quality of the images or no? This is number one. Now nobody is really concerned about the migration of the lead, or it's going to cause any burning issue or some kind of burning sensation to the patient while you are doing the MRI. And many institutions changing their protocol too with that.
That's exactly why. That's Yusuf, just to support what Wael said, that when I started in my center, they don't MRI any patient with ICDs. Now 6 years in, now we do it, and so you just have your department to be more comfortable with doing it.
Exactly. Okay. And then,
Yusuf, if I may add one thing on the artifact part, for like spine MRI, I don't think that's affecting much. If you're talking about a cardiac MRI, right? So if you're talking about scanning brain MRI or lumbar, that artifact is the issue with that safety and the heating.
Yeah, cardiac MRI, yes, that's right. And Dr. Gusbi, there's a question about the effect of those monitoring devices on ICDs and pacemakers. Dr. Fathi, Ms. Manash, your opinion. We can have your opinion about that. Dr. Fathi Idris. Maybe he's not with us. Mohamed, what do you think about equipment, like monitoring equipment, those tools that patients have, interactions, generally speaking, pacemaker interactions, what is safe and what can patients use for pacemakers and ICDs?
Most of the new devices, their algorithm smart enough to overcome most of the artifact. The only I think he mentioned also the iPhone. There's some reports on the new iPhone that the magnet in the phone is big enough to confuse the device. I think a couple of the manufacturers have sent already an alert about the latest iPhone to be careful. So it can act like what happens when you put a magnet on the device. So this is the iPhone. As far as monitoring devices, I mean, first of all, why would you put a monitor on a patient with a pacemaker unless you have a doubt about the pacemaker?
No, those like notification, like those older folks who have a device they push when they're in emergency. I think that's what I understood.
Yes, that's right.
Yeah. So that's safe. Yeah.
Yeah, that should be okay.
Yeah, that should be okay. Most equipment, like I mean, it's the RF, like the radio frequency energy. I mean, if it's a high frequency, there's some. I'm not an expert in that field, but AMI can happen with some, like for example, arc welding. For ICDs patients, we recommend they don't arc weld. No chainsaws. Pacemaker, generally I tell patients they can use microwave. Everyday equipment is fine. Even going through the store, like to Macy's or any store, they can go through the magnetic things for detection of
airport security, all of that stuff. Generally should be okay, should be safe. They're going to pass for a second into it and shouldn't happen. I think the only situation, don't go inside the microwave, right?
Yeah, that's why I tell them not to stick their chest in the microwave. Definitely.
Yusuf, just to have quick comment, if you don't mind, about the abandoned leads. That's really good information that we still here in our center use the precaution by not taking those patients to the magnet, to the MRI. And to add on, if you have an MRI compatible and for some reason you use different lead for that MRI compatible, so you have MRI compatible lead from Medtronic, MRI compatible device from Biotronic, the manufacturers say no MRI. Yeah. So for liability for the MRI people, for the radiologists, they're liable. So unfortunately, they don't allow patients to go to the magnet until we have more evidence or guidelines to support the use of that. Although this is very reassuring information, and it's really good to hear. The other thing is, I agree with you about the when not to use the what stuffs are you able to use or not to use for the pacemakers in general. Anything, as you said, can be used in the house except high voltage electricity and high magnet voltages. And if you have anything like will interfere electrically with the device. I have lots of electricians who use different devices and work in high voltage areas. So those patients, unfortunately, they even need to change their job. We have to tell them that. Otherwise, I think most of the stuff like you mentioned are very safe and can be used. In the old devices, though, there were lots of issues with that before, but with the new devices we have nowadays, they are very safe and no limitations.
Can I just ask, is there a difference between an abandoned lead in the ventricle and biventricular pacing with an atrial lead? Is there a difference? So let's say all these two devices will have 3 leads, let's say. Does that make a difference whether the patient can go into the scanner or not? And are you worried about artifact, or are you worried about the lead tip heating?
So cardiac MRI, you're worried about artifact. It doesn't, abandoned lead is abandoned lead, whether it's 2 or 3, or maybe the high risk with more. And heating, like we said, Dr. Wael Busnena mentioned that that's not a huge concern anymore. So
Yusuf, I think the answer to that question is the number of the leads. Obviously, if you have one single lead, it's the quality of your MRI images will be affected. If you have more than one lead, the chance of the image quality will be less. But there is some center where they have protocols where they still could get valid information from the MRI scan, not as good as in someone who doesn't have a pacemaker. So the more leads that you have, the more artifact, the less quality of the MRI, but it doesn't mean you cannot do it. Any concern about MRI safety with the number of lead, whether it's abandoned or not, obviously, as we discussed, the concern is not as much as it used to be. And I think that's the comment. I think, in my humble opinion, is if you have a center where they're not used or comfortable doing an MRI in someone with pacemaker. If you have someone with CRT 3 leads, they're unlikely to get good quality images, and they're unlikely to give you any useful information from it. So I would be looking into another imaging modality if I was you. Yeah. But can it be done? Are we doing it in our center? Yes, of course we are.
Okay. Dr. Fathi Idris.
Shukran, Yusuf. I think I missed part of the discussion, but now you guys are discussing MRI, but can I ask a question to Mohamed regarding the basic? Could you explain the concept?
I mean, there's a lot to talk about. Mohamed, mashallah, he covered everything in in those 2 talks. But in the future talks, we can talk more about pacemakers. Maybe use some scenarios. It might be easier to understand. I mean, at least now, most of the attendees are familiar with the terms, but how to apply and how to see them and practically can be another talk that we can arrange for, inshallah. I think we need to conclude here. Thanks, Mohamed, for your time and for this excellent talk. Also thanks to Dr. Fathi Idris and Khalid. Barakallah fikum على مساهمتكم. For everyone who has participated, يعني كلكم شكرا لكم. إن شاء الله المحاضرة الجاية حتكون إن شاء الله في شهر 10 بإذن الله بالنسبة للإي بي. بالنسبة للدكتور أيمن سمير, I think there's an interventional coming up, صح؟
inshallah next Saturday history of interventional cardiology دكتور عبد الغني الساعدي, for expert panel حيكون دكتور عبد الغني عبد الرزاق الجهاني ودكتور علي الديوب ان شاء الله.
تمام ان شاء الله. خلاص بارك الله فيكم جميعا ولا ان شاء الله نكون على اللقاء باذن الله.
يوسف مش عارف، ما دام اغلبيه جماعه الاي بي هنا موجودين، لو تحطوا لنا يعني